Thank you very much for that embarrassing introduction and the invitation to be here. It's really nice to have the opportunity to be at my first ESHG, and what a pleasure to be able to speak in front of some dummies, but certainly some bioethic gurus in the audience who I've had the opportunity and pleasure to work with as well. So I'm going to take a bit of a different approach because Martina, you can't follow that talk, and she's laid out such a lovely landscape of the bioethics worlds and the principles. So what I'm going to do is shift and apply some of those ideas and some of the actual debates discussions that have just been raised about the individual and the collective tensions, and apply it to newborn screening and some emerging ethical dilemmas that have arisen in this very important public health program. So for those that are not aware, in most industrialized countries around the world, we take a small sample from the heel through a prick of every baby born in order to test it for several genetic diseases ever since the 60s, when it began with phenylketonuria, and it's expanded to include other disorders to identify things in the 70s such as congenital hyperthyroidism, etc. And the idea in principle has always been, if you can find a disorder early, before onset of conditions, and have a treatment available, then you can effectively reverse or prevent the onset of quite devastating symptoms in a child, and potentially ameliorate any other morbidity associated with it. And so in 2006, newborn screening has been expanding, and I'll get to that in a moment, across the US, Canada, and Europe, including Denmark, in fact. But the CDC, the Center for Chronic Diseases in the US, has certainly described newborn screening as the public health genomic success story of our century, given the fact that it's really credited with saving millions of lives over the years of pretty otherwise sick babies. And the principles that justify the fact that states are essentially able in a routinized fashion to screen millions of babies annually for these genetic conditions have really come down to the classic traditional screening principles developed by Wilson and Jungner under the auspices of WHO, which essentially outline the minimum criteria that's necessary for a population health screening program to essentially initiate population-level screening. And first, we should establish that the disease that we're screening for needs to be an important health problem, that there is a treatment, that we're not just identifying or detecting sick individuals, but there's something we can do about it, that there are facilities to both diagnose and treat individuals that are identified at an early stage, that there is an appropriate test, the test is acceptable to the population, that we understand the natural history of the disorder, we know and we have identified who to treat as patients, the true positives and not the false positives or the true negatives, for example, that the costs outweigh the other expenditures to the healthcare system, and that screening is an ongoing process. But at the very heart of the screening principles is really the primacy of clinical benefit. We are screening, we are testing to identify something that we can treat, that there is clinical benefit in identifying the quote-unquote sick individuals. But there are three primarily important ethical challenges that are developing, that are emerging within the newborn screening program, both in Europe and in North America and across the world, that is increasingly challenging the moral authority that we have as newborn screening programs or public health programs to essentially screen babies in a routinized fashion. When I say routinized fashion, I mean that in most countries, newborn screening is either mandatory, it is implied consent, where it's done as part of routine baby care, where the consent of parents is implied as part of coming for their care to a hospital and part of delivering their children in the hospital. It's part of the battery of other tests and procedures that are performed, and it is assumed that it is appropriate unless a parent specifies otherwise. So what I mean by routinized is that it is not active, consent is not actively sought in most jurisdictions. Of course, there is variations upon that across Europe, which I'll describe. So the first what I wanted to get into is essentially describe as background each of these three ethical issues that are emerging, that are challenging the moral authority that we have to continue routine newborn screening in this way. And the first is the expanded scope of disorders that are being screened for in newborn screening. So with the use of a new technology, tandem mass spectrometry, the ability now is to use the same sample of blood that we take from the newborn heel prick. Instead of screening it for 2, 5, or 10 disorders, now there really is no limit to the number of disorders that we can screen a baby's blood for. And so, and it's essentially as cost effective to screen for 12 disorders as it is for dozens to 100 disorders. So questions have been now, how much do we screen? What do we screen? Where are the limits of screening? And of course, the questions go back to, okay, what are the ethical principles? What are the screening criteria, taking us back to Wilson and Jungner? But because of the challenges of being able to not only screen because we can treat, but screen because maybe we can treat in the future, or maybe there are experimental treatments currently available, that there are some jurisdictions in North America and elsewhere that are starting to screen newborns beyond disorders for which there is established treatment, to include detection of conditions without treatment, those where treatment is not necessarily established or its implications are unknown, and that have a moderate effect on morbidity and mortality. So to put this into perspective with some examples, in addition to PKU and CH, we are also screening for cystic fibrosis, Duchenne muscular dystrophy in some jurisdictions, amino acid disorders, lysosomal storage disorders, where the evidence is equivocal in terms of it reaching the threshold of a high level of evidence to suggest that there is a high degree of reduction in morbidity and mortality. But despite this expansion of newborn screening to many more disorders than what the criteria of primary clinical benefit is to the child, this public health emergency model of screening in a routine fashion without explicit parental consent continues. So I've just described in the US, newborn screening is mandatory by law in most states. In Canada, which is where I live, it's implied consent. People that come to the hospital, it's part of routine baby care unless you otherwise decline. And in Europe, again, the consent models are varied, but it's mostly voluntary with some jurisdictions that have explicit consent. But what I mean by public health emergency, as coined by Scott Grossi, is this idea that it's a public health emergency. If we know that a child and we can detect a disorder early and treat it, then it's an emergency to identify it in a public health screening program. But when we start to move the boundaries and the pendulum swings past the ability for us to treat the disorder, then this question of should we continuously be screening when we can't necessarily treat it, and we're not necessarily telling or offering the parents permission for this, starts to raise challenges. And this is essentially brought to the fore with larger expansions and arguments from from the policy community, from the ethics community, and from clinicians around, well, let's start rethinking what we mean by benefit. Is it just clinical benefit in terms of treatment, or is it other benefits, like if there's no treatment but we can identify the disorder early, then perhaps this avoids the diagnostic odyssey that otherwise parents and their families are searching for years, often under extreme anxiety, test after test, watching their child deteriorate without knowledge of what is the cause of the disorder. Also, there's opportunities, of course, since they're genetic disorders that are identified through newborn screening, to inform families of their risk if they choose to have more children, that in lieu of providing clinical benefit or treatment to the affected child, you can identify reproductive risk for the parents. That might be a warrant or a justification for identifying these affected babies without treatment. Otherwise, others have argued that maybe it's important to provide or identify these babies early because we're able to provide access to experimental treatment, or just because we are able to allow parents to psychologically prepare for the birth of an affected baby. But of course, with the benefits, there are those that start to very emphatically argue for the larger expansion of harms by increasing our screening programs to identify diseases in babies where we don't necessarily have effective treatments. The idea of false positives not being such innocuous harm. In fact, growing evidence shows that there are psychological consequences to identifying false positives through screening programs, that there's anxiety and distress that can occur. The idea of overdiagnosis has certainly started to reach the fore in cancer screening programs where we are identifying otherwise dormant forms of disorders that otherwise would have never necessarily harmed the individual. And so overdiagnosis is a concern as well in newborn screening context. And when we're talking about parents and their children and identifying a child early with a disorder, what effect does that have in terms of the parents bonding with that child, knowing that this child is sick right from the beginning? And are we disrupting the bond between the parent and the child? So these are the larger connotations, the larger ethical issues and the consequences that are at stake when we start to just screen for more and more information, more and more disorders, when there is not necessarily clinical intervention available. So these are the larger ethical challenges that are at stake or in tension is the classical biomedical ethics principles that Martina just alluded to: autonomy, non-maleficence, not to do harm, and justice, in terms of the fact that we are not necessarily asking for informed consent, in terms of that being a cornerstone of biomedical ethics, in view of the public health ethic of trying to screen the population in order to identify the most a number of affected children, to essentially surveil them and provide treatment. So the tension really is between one set of ethics, which holds informed consent as the pinnacle of the cornerstone of biomedical ethics, to make sure that everybody has a choice around testing and the information that's gleaned. But certainly informed consent could be considered the gravestone of public health ethics, when the idea is to screen a whole population, to throw the safety net as far and wide as possible so we can benefit and identify as many sick babies as possible. And so that's the tension at stake when we start to expand the scope of newborn screening beyond the Wilson and Jungner criteria of screen when you can essentially treat and have the systems of care set up. The second emerging ethical issue is the fact that not only are we screening these samples, these blood samples from these babies' heels, but we're storing these. But many jurisdictions, in fact, all at least, store these public health laboratories store these newborn screening samples not only to identify sick children, but for other uses such as quality assurance and forensic investigations, and other secondary purposes such as research, which have led to significant controversy across many jurisdictions, including the US and Canada. This is an example of Texas parents that essentially have taken their public health laboratories in their state to court, saying that it was unethical to have not only taken my baby's blood sample, but use it without my consent for secondary purposes, such as research or forensic investigations. And in fact, the lawsuit concluded by requiring the state to destroy 500 million blood samples that were taken before 2009 and essentially burn them all and destroy all of those samples, because there was the collection of the samples and use for genetic research was deemed as improper, which, as you can imagine, is a goldmine of research, of epidemiological research on a whole population upon millions every year. So there are certainly clearly, again, these tensions between what we're doing in terms of the fundamental goals of ethics, biomedical ethics here, which is when you when you conduct research, as Martina has so eloquently has already stated, we need to inform the participant and give them meaningful choice. Certainly for the storage and use of their samples for research. But again, this is a large tension when this comes into conflict with the larger ethics and the justification for these public health programs, which have at the very primary goal of identifying sick babies. And the sequelae, or the secondary uses of quality assurance, quality control, and potentially research really could jeopardize the underlying and foundational reasons why we're actually conducting these public health programs, which is to identify and treat these sick babies. So again, informed consent, it becomes this teeter-totter, which on the one hand, we support the public health emergency model of identifying, screening to treat without explicit consent from parents in most jurisdictions, because because it's so important to identify and treat and essentially save these babies. But when you start to add on these complexities of other uses of these samples, then you start to really jeopardize the very foundational reason why and the moral authority that we have as a state and as professionals to take the sample for clinical benefit. So clearly, as ethicists and as policy researchers and health services researchers that we are, we develop position statements and guidance. And what's interesting is that the European guidance in this arena, which was led by Martina, and the North American guidance that I had the pleasure to be part of, came to very different positions with regard to the need to consent parents for the use of their newborn screening samples for research or for secondary purposes. The North American statement says that the American Society of Human Genetics encourages states to retain dried blood samples for quality assurance purposes, and the retention of quality assurance purposes should be considered integral, part and parcel to the newborn screening program, because in fact, we can only maintain a strong program if we know that the program's working and the test is working properly, and that the retention of those samples for quality assurance should not require specific permission from parents, because in this framework, quality assurance is considered part of the public health laboratory's responsibility to maintain the standard of screening in terms of the sensitivity and specificity of the test. Whereas the Europeans have started to move towards another opinion, at least in my reading, and Martina can correct me, that they have suggested that if the blood spot is being used after 18 years and not strictly for the benefit of the newborn in terms of its clinical benefit, that the child should have the opportunity to either consent or dissent. So, of course, that requires a different level of engagement with potentially recontacting or allowing for the public laboratories to have to reach out or at least identify those samples and potentially remove them from their cohorts. But that's how heated these kinds of debate can be, where, of course, societies come to different opinions about this topic. And the final emerging ethical issue, which I'm sure is not a surprise or new in our community, is the fact that there's increasing attention to the idea of incorporating genome sequencing technologies for these blood spot samples. And in fact, the NIH have actually not only started to begun funding these types of exploratory programs to look at how genome sequencing can be used to augment newborn screening, but there are proof of principle studies that have already been published to suggest that it's possible, and that in fact sometimes the screening sensitivity could be increased. And of course, the subsequent commentary about the ethical hazards and challenges if we move in this direction. And certainly the very eloquently, as always, Ellen Wright-Clayton speaks about how the use of whole genome sequencing is really very much, again, raising old questions around informed consent with new urgency and are posing new challenges that threaten to overwhelm the newborn screening program. And in many ways, what's happening is we're screening for thousands of disorders, potentially, using these sequencing technologies, among millions of babies annually, which will essentially threaten to overwhelm not only public health laboratories, but individuals with information that's beyond the actual target of the program. And incidentally discover information that's not necessarily, obviously not the intent of the newborn screening program, certainly goes beyond the issue of scope of screening for what's treatable, but if you're opportunistically now screening or discovering incidental information, that you're potentially drowning the medical system, the public health screening program, and potentially patients if there's going to become a duty to disclose that information if it's at least medically relevant to their health. So again, I come back to this figure because I'd like to imprint this balancing, this tension between, again, what we're doing in terms of always consent for any genetic test, especially when it comes to whole genome sequencing, with the idea that we're now moving from a public health program that was about screening and surveillance that will also opportunistically begin screening for disorders that are not necessarily the target of newborn screening and could potentially go beyond, obviously, childhood onset conditions, go beyond treatable childhood onset conditions. And again, this throws the balance and the tension around how we're pushing the boundaries of what was originally a program to identify sick, treatable infants with sick and treatable conditions in lieu of informed consent or in lieu of explicit, onerous, traditional consent models because of the public health emergency, and we're pushing those boundaries more and more with the increasing use of different technologies and the different secondary uses of the samples. And of course, the PPPC, led by Heidi Coward in this domain, have published that a policy statement that really very nicely concludes that we need to, if the primary objective of newborn screening is to identify the clinical benefit and to keep that as the primary reason for screening, that targeted analysis and not whole genome bioinformatic analysis of the entire sequence needs to be upheld, and that the identification of only gene variants conferring a high risk of preventable, treatable disorders that are treatable and preventable in newborn and early childhood should be the focus of newborn screening programs, irrespective of the fact of if whole genome sequencing technologies are being used. So all of these challenges bring to bear the larger collective perspective, which is what we were talking about at the end of Martina's discussion about the challenges between individual consent and the broader collective societal benefit and requirement to screen a whole population to identify the few. And in many cases, we require not only the public's participation, but their sanction, their approval for us to continue doing this, despite these, especially in light of all these ethical challenges, because of how important it is as the public to participate. And the public in large number of jurisdictions are effectively the payers of our public health programs, and they have the most at stake. So public support is very much critical to achieve the clinical benefits that newborn screening programs seek. And in fact, we do know that there are very high levels of public support and parental support and participation currently for a newborn screening program, which we do not want to jeopardize in lieu of these emerging technology and other ethical challenges. But we certainly rely on the public to continue to support newborn screening, both as a public health activity and in terms of its service, who pay for the service, because at the end of the day, we need everybody to participate in a public health program in order to identify as many sick babies and treat them as possible. But again, the ethical issues may challenge the public's participation and expectation of others to participate in lieu of the expanded scope of conditions that we're starting to screen for, the secondary use of the stored samples, and the untargeted use of whole genome sequencing might start to begin to challenge and start to question whether the public really should continue to participate and support such programs. So we're back to the principles. Are all of these changes to the program acceptable to the population? And back to those principles that Martina had described in terms of the collective, should we start to make sure that the public is actually on board with how we're changing the program and the very foundational and critical changes that might actually be occurring in the future? So from an engagement perspective, from a principled perspective of engaging the public in terms of its the principle of citizenry, or from reciprocity, we should make sure that our community that is being at stake, we should engage with and understand their values that are at stake towards the common good of identifying sick babies for which we can treat. And so that all points to the need to really engage with the public. And what I mean by engage with the public is public consultation, having in-depth studies of what the public values, what the public believes, what the public is going to put up with in terms of the moving boundaries, the shifting and widening goalposts of how we're changing fundamentally the newborn screening programs. So what I'm going to turn to now is some research that I did with colleagues back in Toronto, Canada, on these three topics and how the public feels about how we should be moving forward with newborn screening. So these are the studies, and just from a reference perspective, I'm going to give you a quick overview of how we did this. We started with focus groups, and then we moved towards a citizen panel, which is very much a classic public engagement process and method, and then we went towards a national survey. And it's typical to use qualitative approaches, which means discussion-based approaches, to then build a survey that would then meaningfully capture the frequency of an opinion or a view or an attitude across the entire population. So we use focus groups and the citizen panel to explore issues around the scope and storage of newborn screening questions, and we use the national survey to also inquire about the public values and views about use of whole genome sequencing in newborn screening. So let's start with the first two. So we used 5 focus groups of 60 individuals, and we spent a lot of time at the beginning educating this group of individuals around what the disorders are that we screen for, and why and for what purposes we store the samples. And then we brought the same individuals back several months later to then again talk about the system healthcare perspective issues and ethics, which is the fact, because what we heard in the focus groups was you have 9 months to educate parents and get their consent. Why can't we just do this and essentially deal with all these problems that you're raising as ethical issues? And so what we realized is that we need to bring those individuals back and have a conversation about what happens in those 9 months, what are all of the complexity and limitations in the healthcare service provision and in the discussions and in the mindsets of parents going through their pregnancy, and the realities on the ground and the capacity to really have informed consent leading up to newborn screening, and understand what kind of research what we mean when we're talking about research with stored samples. And each of these methods employed both qualitative deliberative discussion with pre-post questionnaires. Before the meeting and after, we had questionnaires to see how participants' views might have changed. So what types of screening, so what we asked participants first was, what types of conditions should we screen for in babies? So if you had the opportunity to advise your government, our government in Ontario, Canada, what it is that you as the public are comfortable in screening all of the population of babies for, would you agree to screen babies for conditions that are treated, for conditions where treatment can only moderately have an impact, reduce the severity of the condition, but certainly the baby would continue to have a condition? Or would you be agreeable as well to identify babies with serious disorders that cannot be treated. So just by a show of hands in the audience, would you be comfortable identifying babies that have disorders that could be treated? And what about those where treatment isn't that cannot cure the disorder, but can certainly reduce the severity of the disorder? And what about those that cannot be treated at all? So what the focus group participants had described is the fact that, just like you, the large majority of everybody was comfortable with screening for treatable disorders and disorders that have only a mild effect on the treatment has a mild effect on the disorder. But there was a bit of more support than that in the audience for even screening for disorders that don't have treatment. But when we brought them back for a citizen panel, again, the majority is still comfortable with essentially screening for everything. What about consent for parents? Do you think parents should be required to have their babies screened such that they don't have to provide consent and we continue to do this as a routine program? Hands up. Do you think they should be strongly encouraged that if they want to actively dissent, that they can, but otherwise it's routinized and we just do it as an implied consent program? Or should they choose without pressure in terms of explicit consent? Write down on a piece of paper that they consent to the program. So a lot of ambivalence actually in the audience across all three categories. And that's actually quite similar to what the public felt. They weren't quite sure that either being required or basically being able to opt in was appropriate, and they started to feel that maybe we should just strongly encourage parents to do that, assuming that the majority will just have their babies screened and maybe few that are aware and have the resources and wherewithal to actively dissent would do that. And in fact, that didn't change when we brought them back to further provide the landscape of all of the challenges and capacity and resource issues at stake. And when we talk about the qualitative discussions that came to bear, certainly folks had described that the benefits of treatment are important, but also the importance of screening for untreatable conditions could just provide information for family, and that is an important benefit, that it provides parents the opportunity to adjust to the potential of having a baby with a condition, to avoid the diagnostic delay, to inform reproductive planning, and to potentially help research. I'm not going to go into the details for time, but I'll just pull out a few examples here. I think the newborn screening is for life. You know, we've got to resolve it and give the best to that so the years ahead will be as productive, healthy, and happy. So the idea is just the best interests of the child are at stake here. And on information, I think it's a big advantage. The parents will, before the child showing clinical symptoms, they'll be able to start educating themselves with the disease and the progression and start looking for symptoms, and they may be able to come to terms with the fact that that their child may not live past 40 and maybe get the support that they need. Whereas those in the focus groups and the citizen panel absolutely were focusing on the harms of anxiety and stigma and unwanted knowledge. That, screening, I think in my mind it's worth it for those 9 families. We gave them proportions, 9 to 1. 9 families would be affected and screened, with 1 family identifying that they have a sick baby. I think it's in my mind worth it for those 9 families to have that experience of a false positive, to avoid this 1 family having whatever the experience is of not catching that affected baby might be like. But other folks had worried about the fact that you're giving people unwanted knowledge. You're screening for information that they didn't provide consent, and certainly didn't provide consent for information that they did not necessarily want. I don't really see it nearly as beneficial. I see this Duchenne muscular dystrophy example, knowing that you can actually do a bit of harm for years ahead of that child. And, I just want to love that child for those years and not know about the fact that they're going to be sick. So then we also talked about storage, and we asked participants to also to describe whether they are okay with keeping the newborn dried blood spot for secondary uses, for quality control, for confirming a child's diagnosis, for anonymous research, for law enforcement purposes, and then we went broad for any purpose. and we asked participants to strongly agree or disagree. And what we found was that a large majority supported storage of samples for quality control, diagnosis, and research, but less so for law enforcement purposes and for broad use. And certainly that held true again in the citizens panel when we had spoken a lot more about research and other uses of the storage of the samples. But when we asked participants about consent for research for their stored samples, their newborn screening stored samples, and we asked them again along the lines of, should parents be required to have their baby's blood spot stored, strongly encouraged, choose without pressure, or we should not store at all? We found that parents largely were ambivalent again, and they focused on both being able to choose and strongly be encouraged, which are clearly opposite end spectrums of the consent model. You either opt in or you opt out, and having both is not obviously feasible. So when we brought them back, you can see that the majority started to move towards the opt-out model, the strongly encouraged, in view of the larger benefit of what we could be doing when we store these samples. And again, from the discussions, there was 3 themes that came out from what the values at stake were for participants. Those that trusted the authorities in storing and using newborn screening samples had felt that it was okay and we didn't need to, we can routinize consent and just do it as a routine model. But those that had low trust in the authorities and governments storing these samples felt that there needs to be more parental consent. And those that were worried about the harms and had highly required consent, and those that were not as worried about the harms did not feel that consent was required. And again, those that were wrestling with the tensions between the individual need for individual choice versus the population interest and the potential benefits from research on these samples would obviously choose different consent models. Those that were okay and favor the population interests and the global good were okay with routinized storage, and those that prioritize individual choice required parental consent. And so here are some examples. They're storing it not for the individuals. They're storing the samples for the populations. They want to get the information out for the research for the population. They're not going to do research on the one guy. They're going to do research for the whole group. It's just for research for the population. It's not research on your son. And another person said, I have trust in the governing bodies to use it appropriately, and I really hope they do to make improvements for other people's lives. And the critics spoke about, one might say just because Research Ethics Board approves it doesn't mean it's my ethics. Maybe they want to do research for something I don't agree with for whatever reason. I still don't think it's beneficial for us to move as a people to a place where we just give blanket consent for everything. If you don't opt out of having your child's blood stored, then you give them some sort of implied consent that it can be stored, but knowing that I have the option to request that my data be destroyed after a 6-month period, then I know that I've chosen not to participate in any long-term research. So we certainly, through these public engagement activities, felt that that citizens' values actually were stable across whichever method that we were experimenting with, either focus groups or citizen panels. But certainly we found that in terms of their values, there was support for a broad scope of screening of many conditions where treatment was available, where even when treatment wasn't available, participants and the public valued just information as perceived as even additional or even a sufficient benefit to be accrued through newborn screening. But even so, there is still an important minority that prefers that there would be a limited scope of screening, and that there was support for anonymous research, and certainly they were accepted. There was a sense of trust and concerns from harms, but there was certainly this trade-off value tensions between what's good for the population versus what I want in terms of what I would value and how I want to be involved in the decision to participate. But certainly in light of the feasibility constraints of trying to consent the entire population of parents every single year to participate in newborn screening and therefore research of the stored samples and to support collective decision-making, the public was willing to concede on active forms of consent for those benefits. Of course, there are some limitations with work, being a non-representative sample, and the fact that we only focus on consent as the one governance structured. So moving on to whole genome sequencing, this is the paper that I led from our group on the public views on participating in newborn screening using genome sequencing. So here we're moving towards the national survey and what the entire representative sample of the Canadian population across the country had felt about participation. And what we did was we took them through a very extensive training module to talk about newborn screening as this. We use the analogy of an airport gateway where you go through the gate, and some babies are going to go through, some babies are going to screen positive and go for follow-up testing, while most babies exit the screening gate, and some babies will be found after follow-up testing, diagnostic confirmatory testing, to be true positives. Others will be false positive and they'll continue on their way. And some will be identified as having a potential mild form of disorder, and we've described this as being overdiagnosed. And so the questions pertaining to whole genome sequencing were as follows. We described newborn screening can pick up different types of, can be used with different types of technologies. The technologies currently used to screen newborns today could change in the future. Recall that newborn screening seeks to identify specific, rare, serious childhood diseases, and they use technologies that detect specific diseases and to minimize the detection of other diseases. And this is to ensure that real benefits are accrued to babies with diseases and avoid harms to other babies who are screened. And then we asked two questions, the individual perspective and the collective perspective. You as a parent, would you choose to participate in this type of newborn screening program, in this current newborn targeted screening program, and also would you consider other parents irresponsible if they choose to refuse to participate? So here we're actually trying to get at the tensions between the individual perspective in participating and the perceived collective responsibility to participate in a program. And so again, we're focusing on the targeted current newborn screening program that looks at only treatable conditions. And then we asked a similar question, and we introduced the concept of genome sequencing and described it as identifying rare, serious childhood disorders that we're doing now, but would also generate large amounts of extra information about the baby's chances of getting all sorts of other diseases now in the future. And then we asked them the same question, would you as a parent choose to participate? And would you consider other parents irresponsible if they refuse? And what we found was that the expected participation is actually significantly reduced with genome sequencing technologies than with current targeted technologies. And this is important because, again, the idea with a public health program is that you try to have virtually 100% uptake or as close to in order to identify all the babies that are affected with treatable conditions. And if you start to introduce a new technology that jeopardizes and reduces participation in that newborn screening program, that you undermine the fundamental purpose of the newborn screening program. And then when we looked at the data about the collective perspective of other parents, the responsibility to participate again is reduced for genome sequencing, and again this is considered significant, but interestingly the responsibility of others to participate is much lower than as a parent would you participate. Then we asked them a series of questions, and for the sake of time I won't go into it, but suffices to say that those individuals that had low trust in the healthcare system and those that had a skepticism towards science, a low confidence in science, were more likely to refuse participation in newborn screening and more likely to assume that other parents should participate in newborn screening. And also other demographics like women were more likely to would also refuse screening with whole genome sequencing, and those with a greater understanding of newborn screening were also more likely to refuse participation in newborn screening with whole genome sequencing, and those that were worried about the benefits and risks were more likely to reduce participation in newborn screening with whole genome sequencing. So what we found was that there was a willingness to participate, the willingness to participate in newborn screening was actually reduced with whole genome sequencing compared to current targeted technologies that identify serious treatable conditions. as was the perception of a parental responsibility to participate in whole genome sequencing newborn screening, and that factors associated with reduced participations was those that were skeptical towards science and that had a greater appreciation towards the harms and benefits of newborn screening. And that our results suggest that integrating whole genome sequencing into newborn screening might actually reduce the public participation in newborn screening and in fact challenge the moral authority that newborn screenings programs rely upon to ensure the population benefits are accrued to those affected babies. And of course, limitations to all science here is that our sample demographics show that our sample is better educated and has a higher income, and that, of course, we were talking about hypothetical participation. We did not obviously measure actual participation because obviously whole genome sequencing and newborn screening does not exist. And in a larger context, though, we have to think about what role does the public have on engaging in ethical debate and providing their collective perspective on ethical principles. And of course, there is an increasing calls to incorporate the public and their opinion into policy decisions, and certainly it's seen as a way to improve transparency and oversight and potentially come at more ethically sound principles and clinical and public health programs. And however, there's obviously larger questions around how we effectively mobilize those communities that we don't hear about in research as often as we should, and certainly what we should do when our ethics as experts, quote unquote, is in conflict with what the public believes, and what should prevail in terms of whether we should go with a public opinion or what we should go with considered expert opinion about the direction of the program. So I just wanted to end with some thanks to the research team as well as financial support of our Canadian government. Thank you very much.